Infectious diseases, preventive medicine and clinical conferences concerning Species 3, 2024 to 2025, horse diseases, equine infectious encephalitis, equine flu, Rhino pneumonia-viral abortion of mares, GOURME, Borna disease, equine arteritis. Emerging infectious diseases of horses have become a major problem for health authorities in the EU in recent decades. Eastern equine encephalitis, Western equine encephalitis, Venezuelan encephalitis, and Japanese encephalitis viruses are 4-RNA arbovirus, responsible for lethal encephalitis in humans and horses. These diseases are considered emerging and are included in the list of 10 diseases recently deemed priorities. A nervous syndrome is the set of symptoms linked to a dysfunction of the nervous system of central, peripheral, or neuromuscular origin. It can manifest itself through changes in behavior, posture, gait, and/or through abnormal movements and wasting of muscle masses. Nervous conditions are relatively rarely diagnosed in equine veterinary practice. Studies, some dating back around 15 years, show that these nervous conditions represent the fourth cause of mortality in horse. Among the causes of nervous conditions, infectious or parasitic diseases come in third position, behind traumatic origins and congenital malformations. In particular, the viruses causing equine encephalitis are important to detect, either because they are zoonotic agents, such as West Nile viruses, WNV, or rabies, or because they have a major economic importance in the sector. Equine virus such as herpes virus type 1, EHV1, or because they are at risk of emergence, thereby presenting a potential threat to Europe, Eastern equine encephalitis, EEEV, Western, WEV, and Venezuelan, VEEV. However, the diagnosis of equine viral meningoencephalitis is very complex in veterinary medicine due to non-pathognomonic symptoms of the infection, and difficult laboratory diagnosis due to lack of specificity of serological tests, and a pathogen-targeted molecular approach. Host species groups, geographic origins and potential European vectors considered to analyze the risk of introduction into the EU of Eastern equine encephalitis, EEEV, Eastern equine encephalitis viruses, WEV, Venezuelan encephalitis, VEEV, and Japanese encephalitis, JEV. Host species such as horses, birds, rodents, reptiles, primates and pigs are identified, and the main European vectors are mosquitoes belonging to the genera Aedes and Culex. Etiology: 4 exotic encephalitides. Japanese equine encephalitis, Venezuelan equine encephalitis, Eastern and Western equine encephalitis, defined because they present common characteristics, notably by their mode of transmission and their clinical expression. These are viral diseases, which can cause severe neurological damage, but are also expressed in asymptomatic form more or less frequently, depending on the encephalitis concerned. Exotic equine encephalitis is caused by viruses of the Flaviviridae family for ENG and Togaviridae for the others. These viruses are of major importance in public health at the global level. Their expansion is part of the broader context of that of numerous vector-borne diseases which are increasingly affecting animal and human populations. These 4 exotic encephalitis are zoonosis, diseases transmissible to humans. In the EU they are part of first category of diseases with major health hazards. Epidemiology: Eastern, Western and Venezuelan equine encephalitis are present throughout the American continent. Japanese encephalitis affects all of Southeast Asia, including Japan and Indonesia, and extends to northern Australia. The geographic distribution of these diseases is expanding, but does not currently reach Europe. Arboviruses, responsible for these encephalitis, are transmitted mainly by blood-sucking arthropods, insects that feed on blood, particularly mosquitoes. Reservoirs exist for the 4 pathogens. The reservoir species are mainly birds and rodents, WILD, but also pigs for Japanese encephalitis. The risk of introduction of equine encephalitis is increased by the increasing number of international exchanges of people and animals, particularly equines. Note, however, that equines are epidemiological dead ends for EG, EEO and E incapable of ensuring the infection of new arthropods after their infection and that they are reservoirs only for EVE. The risk must be taken into account all the more as the potential impact generated by the introduction of one of these arboviruses would be considerable. Public health term, significant case fatality rate, particularly in children, serious neurological sequelae. High economic cost, cost of medical care, cost of human and animal vaccination when it exists, loss of animals and reduction in production, obstacles to commercial animal trade. Ecological cost, consequences of disinsection on the environment and biodiversity in particular, symptoms. The clinical manifestations most frequently encountered in this encephalitis are hypothermia, associated with anorexia. Neurological symptoms correspond to changes in posture, stiffness, in coordination of limbs, ataxia, or in behavior and vigilance, aggressiveness, hyperexcitability, unconsciousness. Symptoms can worsen and lead to the death of the animal. Although these diseases are quite similar in terms of clinical signs, the incubation time is more or less long, depending on the agent concerned. Short period for EVE, 1 to 5 days. Average period for EEA and EEO, 5 to 14 days. Long period for EG, almost 21 days. These 4 encephalitis are also characterized by their severity. Indeed, the fatness rates, number of fatal cases over the number of affected subjects, for each of them differ, between 75 and 100% for E, 20 to 50% for EEO in case of encephalitis, 40 to 80% for EVE and 5 to 30% for EG. Venezuelan equine encephalitis v. Enzootic strains cause limited symptoms and weaker or even non-existent viremia. Epizootic strains are associated with a high frequency of encephalitis, often fatal, up to 80% of animals, and with high viremia. The incubation period is 1 to 5 days. The first clinical signs are fever, anorexia, drowsiness and depression. Symptoms of encephalitis may then develop after a few days: weakness and ataxia, muscle spasms, incoordination, head pushing, circling, and convulsions. Some equines may experience diarrhea and colic. Death can occur a few hours after the onset of neurological symptoms. Cases of sudden death have also been reported. Equines that survive may suffer permanent neurological damage. Eastern and Western equine encephalitis EEO. The incubation period is 5 to 14 days. The majority of infected horses develop an acute and fatal attack. Survivors present neurological sequelae. The illness is generally less serious in cases of EEO. The first clinical signs are fever, anorexia and drowsiness. Symptoms of encephalitis may then develop: mental impairment, hypersensitivity to stimuli, involuntary muscle movements, pushing with the head, circular movements, difficulty swallowing, ataxia, paresis, paralysis and convulsions. Phases of excitement or intense itching can also be observed. Some animals may experience diarrhea, constipation or significant weight loss. Japanese equine encephalitis G. The infection is generally asymptomatic in horses, however, some animals may develop neurological signs and the mortality rate is high. The incubation period is 8 to 10 days. Some horses show fever, anorexia, drowsiness and congestive or yellowish mucous membranes, lasting 2 to 3 days, then recover. Other animals may develop encephalitis in addition to these symptoms. We observe 2 forms of encephalitis, a moderate form and a more severe form, around 5% of horses. Medium shape, animals have difficulty swallowing, incoordination, neck rigidity, transient, paralysis, impaired vision but recover within 1 week. Severe form, there is high fever, violent behavior, sometimes blindness, generalized sweating and muscle tremors. This form often leads to death within 1 to 2 days. Sequelae such as ataxia may persist. Diagnosis. The diagnosis of arboviruses is complex, and laboratory tests must be linked to clinical and epidemiological elements. Autopsy, macroscopic and histological examination of nervous tissues. Serology, ELISA test, the most common, or serum neutralization test, reference test virology, PCR or viral isolation from blood/serum, CSF, brain, cortex, thalamus, corpus striatum, or spinal cord. Other laboratory techniques are available. However, they require work on the living virus, in specialized and secure laboratories. National Reference Laboratory, which carries out the diagnosis of these encephalitis, diagnosis AG isolation. The definitive method for the diagnosis of E or WE is virus isolation followed by typing. E virus can usually be isolated from the brain of horses unless more than 5 days have elapsed between the appearance of clinical signs and the death of the horse. E virus can frequently be isolated from brain tissue, even in the presence of a high serum antibody titer. WE virus is rarely isolated from tissues of infected horses. Brain is the tissue of choice for virus isolation, but virus has been isolated from other tissues, such as liver and spleen. During EVE infection, viremia coincides with the onset of pyrexia within 12 to 24 hours after infection. Viremia generally ends 5 to 6 days after the onset of infection, and coincides with the production of neutralizing antibodies and the appearance of clinical neurological signs. Often, EVE viruses cannot be isolated from the brains of infected equines. Blood samples for virus isolation should be performed on febrile animals closely associated with clinical encephalitis. Case. It is recommended that a set of these tissues be collected in duplicate, one set for virus isolation and the other set in formalin for histopathological examination. Specimens for virus isolation should be sent refrigerated if they can be received at the laboratory within 48 hours of collection, otherwise, they must be frozen and sent with dry ice. WE and V viruses can be isolated in a number of cell cultures. Cell cultures used are primary fibroblasts from chicken or duck embryos, continuous cell lines from African green, monkey kidney, Vera, rabbit kidney, RK13, or baby hamster kidney, BHK21. WE and V viruses will produce a cytopathic change in cell culture. Cultures that appear infected are frozen. Fluid from thawed cultures is used for virus identification. The newborn mouse is also considered a sensitive host system. Inoculate intracranially 1 or 2 liters of mice aged 1 to 4 days. The mice are observed for 10 days. Mice that die within 24 hours of inoculation are discarded. From 2 to 10 days after inoculation, dead mice were collected daily and frozen at 70 degrees Celsius. Mouse brains are harvested for virus identification. A second passage is only performed if the virus cannot be identified from mice that die after inoculation. Chicken embryo is considered less sensitive than the newborn mouse when used for the primary isolation of WE or V viruses. Tissue suspensions can be inoculated by yolk root into 6 to 8-day-old embryonated chicken eggs. There are no diagnostic signs or lesions in embryos infected with these viruses. Inoculated embryos must be incubated for 7 days, but deaths usually occur between 2 to 4 days after inoculation. If this method is used, precautions should be taken to avoid aerosol exposure to personnel, as infected birds may shed highly infectious virus. PCR. Several conventional PCR methods for the detection of WE or V viral RNA in mosquito and vertebrate tissues have been described, although few have been extensively validated for mammalian samples. A multiplex PCR method has been developed to accelerate the differential diagnosis in cases of suspected E or West Nile arboviral encephalomyelitis in horses. The assay has improved speed and sensitivity compared to virus isolation in cell culture and has been used extensively in National Veterinary Service laboratories over several arbovirus seasons. A real-time RT-PCR for the detection of North American E and WE viral RNA variants was developed and validated on a limited panel of field samples. It demonstrated superior sensitivity compared to virus isolation in Vera cell culture. Molecular diagnosis of high-throughput real-time RT-PCR based on light cycler technology, which makes it possible to detect in a single test the majority of viruses responsible for nervous conditions in horses. 2. Antigen capture ELISA developed for monitoring E in mosquitoes. This can be used in countries that do not have facilities for virus isolation or RT-PCR. 3. Immunohistochemical, IHC, procedures useful for the diagnosis of E because they are carried out on fixed tissues. The envelope protein of the E virus is targeted in IHC. Necrotic foci and inflamed areas of the brain are examined. In horses infected with E virus, positive staining is observed particularly in neurons and associated dendritic processes. However, failure to identify viral antigen in the equine central nervous system does not exclude infection. Serological confirmation of E or W virus infection requires a fourfold or greater increase or decrease in antibody titer in paired serum samples collected 10 to 14 days apart. Most horses infected with E or W virus have a high antibody titer when clinical disease is observed. Therefore, a presumptive diagnosis can be made if an unvaccinated horse with appropriate clinical signs has antibodies against only E or W virus. The detection of IgM antibodies by ELISA may be suggestive of an acute infection or recent exposure to the virus. Therefore, the interpretation of the serological results must be made in conjunction with the clinical signs and the epizootic situation. 1. Complement binding is frequently used for antibody detection, although antibodies detected by the CF test may not persist as long as those detected by the high or PRN tests. In the absence of an international standard serum, the antigen must be titrated against a locally prepared positive control serum. The normal antigen, or control antigen, is mouse brain from uninoculated mice extracted and diluted in the same manner. 2. Inhibition of hemagglutination. The antigen for the high test is the same as described above for the FC test. The antigen is diluted so that the amount used in each hemagglutinating unit, HAU, is 4 to 8 times that which agglutinates 50% of the red blood cells in the test system. 3. ELISA kits for the detection of IgM from equine samples are commercially available. The ELISA is performed by coating flat-bottomed plates with anti-equine IgM capture antibody, SAHU. 4. Neutralization by plaque reduction. The NRP test is very specific and can be used to differentiate between E, W and V virus infections. The NRP test is carried out on cell cultures of duck embryo fibroblasts, VERA, or BHK21. Differential diagnosis in equidays. RAGE. Rhino pneumonia, nervous form, equine herpes virus 1 West Nile fever, West Nile virus verminous encephalitis. Protozoal meningoencephalitis, Sarcocystis neurona, Neospora caninum botulism. Hepatic encephalopathy. Borna disease virus, immunoprophylactic measurements. Inactivated vaccines against E and W viruses are commercially available. Attenuated E and W virus vaccines have not proven satisfactory. Vaccines authorized for use in the United States are prepared using the following combinations: E and W, E, W and V, and E and V. Additionally, tetanus toxoid, inactivated influenza virus, inactivated herpes viruses, EHV1 and EHV4, and inactivated West Nile virus have been combined with E and W or E, W and V. Vaccines prepared from viruses propagated in cell culture and inactivated with formalin. Recommended vaccines against V infection are an attenuated virus vaccine, strain TC83, and an inactivated virus preparation made from this strain. The inactivated vaccine should be administered in 2 doses with an interval of 2 to 4 weeks between doses. Annual revaccination is recommended unless otherwise specified by the manufacturer. The attenuated vaccine should be reconstituted with saline and used immediately. Multi-dose vials are kept on ice while the vaccine is in use. Any vaccine not used within 4 hours of reconstitution should be safely discarded. Animals over 3 months old are vaccinated subcutaneously in the cervical region with a single dose. Annual revaccination is recommended. Treatment and prevention. Currently, there is no known specific or effective antiviral treatment for equine viral encephalitis caused by arboviruses. Supportive treatment, however, can be considered. Medical prevention. Several vaccines have been put on the market to prevent infection or reduce the incidence of arboviruses in equines. Vaccines exist against these different viruses in several third countries, however, these vaccines do not have marketing authorization in the European Union and therefore cannot be used there without authorization from the competent authority. In France, vaccination against these diseases is not authorized. On the other hand, vaccinated equines can be admitted to French territory. Health prevention. Disinfection of premises and equipment, use of conventional disinfectant products. Vector control, territorial development, reduction of ecological niches, or use of insecticides and repellents, outings of equines outside periods of high vector activity, dusk, legislation. These diseases are notifiable, they must be notified without delay to the local authorities. In case of suspicion, the keeper must call an approved veterinarian, who inspects the horse within 24 hours. If the suspicion is proven, the veterinarian must notify the suspicion to the local control unit, and ensure that suspected horses are kept away from places where other susceptible horses or animals could be contaminated. When a suspicion of equine viral encephalitis is notified, implement official measures, including collection of samples and analyses to confirm or refute the infection. Ban on the exit of suspected animals and blood products and ban on the use of these products in order to prevent the spread of the disease during the period of suspicion. If necessary, other measures can be put in place. Prior authorization for any movement of sensitive animals. Isolation of equines and other sensitive animals. Control measures. Epidemiological investigation to identify the origin of the disease and whether other animals or farms have been infected. Counting of equines and other receptive animals. Destruction of biological product stocks from an infected donor. In Venezuelan viral encephalitis, the following measures apply. Isolation of all equines. Killing and destruction of all equines. When the situation permits. Killing and destruction of infected equines. Carrying out a diagnostic tests, 15 days after the elimination of infected equines from other equines. Prohibition of equine movements. In the event of Venezuelan viral encephalitis, measures in the home are lifted. At the earliest 30 days, after the elimination of all equines and the cleaning, disinfection and disinsection of premises, equipment and vehicles, at the earliest 6 months after the killing and destruction of the last infected equine, and provided that the equines on the farm have been submitted with a negative reaction to a diagnostic test. For other viral encephalitis, intra-community exchanges of equines from the infected farm are prohibited, for 6 months from the date on which the equines were slaughtered or eliminated. A highly contagious respiratory disease, equine flu, can have significant economic repercussions for the equine industry. At the end of 2018 and the beginning of 2019, several outbreaks of horse influenza were declared, both on breeding grounds and in sports and racing stables and equestrian centers. Vaccination is essential to protect the health of equines and prevent the spread of disease. Etiology. Equine influenza is an acute respiratory infection of horses, donkeys, mules and zebras caused by two distinct subtypes H7N7, formerly named Equine, and H3N8, formerly named Equi2 of the influenza A virus, within the genus Influenzavirus A of the family Orthomyxoviridae. The flu is very contagious, it spread quickly in a stable. Transmission between different species is rare, but transmissions between birds or dogs and equines have already been reported. No transmission of influenza from horses to humans, or vice versa, has ever been observed. Influenza viruses are changing over time, thus escaping the equine immune response. These variations require regular changes to the composition of vaccines. Epidemiology. The flu is an extremely contagious disease. It can affect most of a stable's workforce within a few hours. Transmission is mainly direct, between horses, the virus being not very resistant in the external environment, but can also be indirect via equipment or people. Transmission occurs by inhalation of aerosols particles emitted by horses. Sick when coughing. A horse excretes a very large quantity of virus. These aerosol particles can be transported very far. Equines infected but expressing few or no clinical signs, healthy carriers, can also transmit influenza to other equines during close contact. Epidemiology incidence EU. In the EU, influenza is not a regulated disease. Surveillance is carried out thanks to voluntary declarations from the holders concerned, via Veterinarian's Sentinel. More information on professional sub-networks such as respiratory syndrome. At the end of 2018 and the beginning of 2019, 23 outbreaks of influenza were declared as of March 13, 2019. Very diverse structures were affected in the leisure, sport and racing sectors. During this same period, the flu circulated widely in Europe. Summary of confirmed equine influenza outbreaks declared between 2014 and 2019. Clinical. Incubation is 2 to 5 days. General signs: fever, often greater than 40 degrees Celsius, associated with depression and anorexia. Respiratory signs: a strong dry cough, occasional to hacking. A serous, translucent, nasal discharge the first few days, becoming mucopurulent, particularly in cases of bacterial superinfection. In a stable, clinical signs are more or less exacerbated depending on the individual, particularly depending on their vaccination status with regard to the disease. Some horses do not show clinical signs or only discrete signs, moderate and fleeting hypothermia. These horses can, however, carry the virus in their nostrils. Healing generally occurs within 1 to 2 weeks, however regeneration of the airways requires at least 3 weeks, during which the horses must be rested. Without a rest period, the respiratory tract is vulnerable to the invasion of opportunistic bacteria, leading to the appearance of a secondary bacterial superinfection. Diagnosis. Identification of pathogen. Embryonated chicken eggs and/or cell cultures can be used for virus isolation, from nasopharyngeal swabs, or nasal and tracheal washes. Isolates should always be sent immediately to an ENG reference laboratory. Infection can also be demonstrated by detection of viral nucleic acid or antigen in respiratory secretions using reverse transcription polymerase chain reaction (RT-PCR) or enzyme-linked immunosorbent antigen capture assay (ELISA), respectively. Serological tests. The diagnosis of influenza virus infections is generally carried out only by tests on paired sera. The first sample should be taken as soon as possible after the appearance of clinical signs, and the second approximately 2 weeks later. Antibody levels are determined by hemagglutination inhibition, high, simple radial hemolysis (SRH), or ELISA. Diagnosis and treatment. Clinical signs as well as the rapid diffusion of the disease in a stable guide the diagnosis. The certitude diagnosis is established by testing for the virus, PCR test, on a nasopharyngeal swab. There is currently no specific treatment for influenza, which is a viral disease. In the event of a bacterial superinfection, antibiotic treatment is administered. Symptomatic treatment is recommended to alleviate clinical signs, in particular to reduce fever, nonsteroidal anti-inflammatory drugs. Horses must be rested at least 3 weeks after the end of clinical signs, in order to promote healing of the damaged respiratory system. Prevention. Vaccination of all equines is strongly recommended, especially since the effectiveness and safety of available vaccines have been demonstrated. It allows a significant reduction in clinical signs, and in particular the risk of bacterial sore infection and viral excretion at the origin of the spread of the disease. In a stable or during an equestrian event, it is important that the majority of horses, including those that move little, are vaccinated. Indeed, It is considered that the vaccination of 80% of equines makes it possible to prevent an epidemic in a population. It is recommended to vaccinate foals from the age of 6 months, as this population is more sensitive to the influenza virus. Before 6 months, maternal antibodies present in foals, if the mother is vaccinated, as well as an immature immune system, could lead to a reduction in the effectiveness of vaccines. Older horses have an alteration in their immune system and therefore respond less well to vaccination. An increase in the frequency of vaccination boosters is recommended. Prevention protocol classically recommended by the producers of the various vaccines available on the market is as follows. Primary vaccination. First 2 separated by 3 to 6 weeks. Last 2 separated by 5 to 6 months. Annual booster injections. This protocol may vary slightly depending on competition regulations and racing codes. Immunity appears 14 days after the second primary vaccination injection, and lasts between 6 and 12 months. Boosters every 6 months are recommended for horses frequently participating in risky equestrian events, large concentration of equines, competitions with on-site accommodation. For insemination, stallions used in artificial insemination, stallions and mares of certain breeds, used in natural breeding. Older horses, greater than 20 years old, have a lower immune response following vaccination. Some horses do not develop optimal immunity after vaccination. These poor responder horses are generally partially protected and can excrete significant quantities of virus. Equine herpes virus 1, EHV1, and equine herpes virus 4, EHV4, constitute 2 distinct groups of viruses. Both are prevalent in horse populations worldwide, and are a major cause of respiratory disease. Transmission occurs through direct or indirect contact, with infectious nasal secretions, aborted fetuses, placentas or placental fluids. A horse's susceptibility to infection depends on the strain of the virus, the immune status of the animal, the state of pregnancy and possibly age. Viruses can survive for several weeks in the external environment, straw in the stall, etc., hence possible contamination between horses that do not have direct contact with each other, via these transmission vectors. However, viruses are sensitive to common disinfectants, soap, Cresil. Epidemiology. Infection of broodmares occurs most often when new horses are introduced to the breeding stock, purchase, boarding, or during a stay at another stud for breeding. Abortion can take place within 9 days to 4 months following contamination. The origin of a rhino pneumonia abortion can be either an infection of the mare by a horse suffering from a respiratory form, either an infection of the mare by contact with the runt of a neighboring mare, or a reactivation of a latent virus hosted by the mare herself. Epidemiological cycle of EHV1 infections, illustrating the central role of latently infected carrier horses as biological reservoirs from which the virus is perpetually transmitted to new generations of equine hosts. The infection is benign or invisible in horses immunologically sensitized to the virus by a previous infection. Most horses are carriers of EHV1 and EHV4 viruses in an inactive state. 60 to 70% of horses are latent carriers. The infection remains dormant for most of the horse's life, although stress, or problems with the immune system, can cause the disease to wake up and shed the infectious virus. Epidemics of respiratory diseases occur every year among foals in areas with high horse populations. Most of these outbreaks are caused by strains of EHV4. Infection of pregnant mares with EHV1 can lead to abortion 2 to 12 weeks after infection. Nervous system disease is another possible result of a specific strain of EHV1 infection. Symptoms: respiratory form, due to EHV1 or EHV4. Illness is flu-like, fever, cough, runny nose, for 1 to 2 weeks, more frequently in the fall and winter. It can be more severe, or complicated by secondary bacterial infections, especially in horses in training. The infection can also go unnoticed, particularly in foals and yearlings at breeding, expressed by an episode of cough and runny nose, sometimes without seriousness. Abortive form, mainly due to EHV1. Abortion occurs without warning signs, no vulvar discharge, no milky flow, most often at the end of gestation, 9th-11th month, but can occur from the 4th month. The fetus and placenta are expelled without difficulty, the mare is not sick. A mare who aborted due to rhino pneumonia is not protected against abortions in subsequent years. In some cases, the foal is born full-term and alive, but has breathing difficulties and dies, most often within 3 days. These foals are highly contagious to other horses. Nervous form, mainly due to EHV1. Various nervous disorders, but not necessarily associated on the same horse, appear. We find locomotion disorders which can go as far as paralysis, paralysis of the penis, absence of bladder contractions, signs of damage to the central nervous system. Nasal discharge in a weaned foal with a febrile respiratory tract infection, to EHV1. Full-term newborn foal infected with EHV1 and showing respiratory distress. Clinical deterioration of congenitally infected neonatal foals occurs rapidly and the prognosis is always serious. Equine fetus aborted following equine herpes virus 1 infection. The fetus is still attached to the placenta and enclosed in its amnion. Liver damage in an abortion due to rhino pneumonia. The small white dots are foci of necrosis, tissue destruction. Lung damage in a runt, congestion and necrosis, due to rhino pneumonia. Diagnosis. Search for the virus is done from the runt, and the placenta, sometimes the only contaminated organ, or from a deep nasal swab, respiratory form. Testing for antibodies, indicating that the animal has been in contact with the virus, from a blood sample, from the mare in the event of an abortion. This technique is less reliable due to possible interference with antibodies produced in vaccinated animals, and a single analysis generally does not allow conclusions to be drawn. When a recent infection is suspected, look for an increase in the level of antibodies in 2 sera taken 14 days apart. The combined use of 2 techniques makes it possible to be more precise. Search for early antibodies by complement fixation and later antibodies by seroneutralization. Treatment. There is no specific treatment, we treat the symptoms. Prevention. Breeding management. Separate brood mares from other horses that go outside the stud for competitions. Quarantine new arrivals for 3 weeks. Start the day's work with pregnant mares, to avoid transmitting viruses from other animals to them. During abortion or the birth of a weak foal, always consider the possibility of rhino pneumonia. Destroy the litter and disinfect the box or pasture area where it was found. Isolate the mare for 1 to 2 weeks, treat her after the other animals and then disinfect carefully. Be careful especially if the foal is alive and requires intensive care. This is a very important source of contamination for other mares by the staff intermediary. Prevention. Vaccination. Compulsory for stallions and brood mares, French trotters and thoroughbreds, and strongly recommended for others. A primary vaccination with 2 injections 1 month apart, followed by a booster at 6 months if possible, then annual boosters. On pregnant mares it is possible to give boosters at 5,7,9 months of gestation. We must think in terms of breeding prophylaxis and not individual prophylaxis. Current vaccines do not definitely prevent abortions. When the virus is introduced into a brood mare population, the percentage of abortions is simply lower if they are vaccinated than if they are not. On the other hand, vaccination of the entire workforce limits the circulation of the virus and its re-excretion among latent carriers. There is no point in hyper-vaccinating brood mares if the other horses on the farm are not vaccinated. Streptococcal infections have an important role in equine medicine worldwide and can cause serious illnesses characterized by various symptoms that are often fatal in the affected horse. There are 2 main pathogenic bacterial subspecies belonging to the species Streptococcus. Streptococcus equi ssp. Horse. Streptococcus equi ssp. Zooepidemicus. GOURME is caused by infection with Streptococcus equi, which leads to inflammation of the upper respiratory tract, mucopurulent nasal discharge, and inflammation of the regional lymph nodes. This infection very quickly leads to the formation of an abscess, generally submandibular, which may be small and disappear spontaneously, or which may become very voluminous and open, requiring adequate treatment. Strangles is a very contagious disease, and even if the horse shows no apparent clinical signs, it can be a carrier and spread the infection. This means that in the absence of adequate preventative breeding methods and a vaccination strategy, infection can lead to significant outbreaks of strangles in equine populations. Zooepidemicus is also known to cause paralysis in foals, polyarthritis, and isolated abortions in pregnant mares. Symptoms. Symptoms may vary depending on the streptococcus involved. Streptococcus equi SSP infection. Horse. Contagious infection characterized by the appearance of abscesses in the lymph nodes draining the mucous membranes of the upper respiratory tract. Incubation period, 3 to 6 days. The first sign is often the animal's refusal to eat and drink. Fever up to 41 degrees Celsius. Catarrhal inflammation of the mucosa of the upper respiratory tract and enlargement of the lymph nodes of the pharynx and mandibular region which present abscesses. Mucopurulent nasal discharge. In very severe cases, infection of the central nervous system or heart. The disease progresses over approximately 2 weeks in a horse, but an epidemic within a breeding farm can extend over several months. The chronic form, also called bastard strang, can appear and lead to infection of other organs, in addition to the upper respiratory tract. Symptoms. Streptococcus infections equi SSP. Zooepidemicus, isolate most frequently encountered in diseases of the respiratory system. May cause venereal infection, potentially responsible for isolated abortions. May lead to paralysis in foals, polyarthritis. Diagnosis. GOURME can be diagnosed based on clinical signs, although the enlarged lymph nodes in the head and neck characteristic of the disease are not present in all horses. Until now, the bacteria were cultured from nasal washes and swabs. This diagnostic method can sometimes lack precision because at an early stage of infection, it is possible that the horse does not excrete bacteria or that the bacteria is destroyed before the sample reaches the laboratory. The most reliable method is to look for the DNA of the bacteria, which also allows us to distinguish between the two subspecies S. equi and S. zooepidemicus. Treatment. Treatment of horses with GOURME generally depends on the stage and severity of the disease. The opinion of veterinarians regarding the use or not of antibiotics remains very divided. However, most cases of strangles do not require treatment, apart from rest, a heated, non-humid box and good quality soft, moistened and palatable food, with the disease continuing its course normally. The horse must have water and food easily accessible. Horses with early clinical signs. During an epidemic, the immediate use of antibiotics in new cases during the early acute phase characterized by fever and weakness, can be curative and help prevent the formation of focal abscesses. Antibiotic treatment can be administered for 3 to 5 days. Penicillin is generally considered the product of choice in the treatment of non-pneumococcal streptococcal infections. Other antibiotics may also be used depending on ease of administration and site of infection. Prevention. Good hygiene and livestock management are essential to stem the spread of S. equi infections. Infected horses should be separated from clinically healthy horses. Precautions should be taken, including exercise periods for infected horses should be scheduled after those for healthy horses to avoid any risk of transmission of the bacteria to unaffected horses or buildings via riders. Infected horses should not have access to the starting stall or other similar types of equipment. Direct contact between horses should be avoided. People in contact with horses during exercise should immediately use hand sanitizer after each contact. Vaccination allowed a clear reduction in the incidence and the severity of associated symptoms. Vaccination is only indicated in healthy horses, showing no symptoms of strangles or any other disease. Borna's disease, non-purulent meningoencephalomyelitis affecting horses and sheep. described for the first time at the end of the 18th century in southern Germany, where it occurred sporadically. It owes its name to the town Borna in Saxony, where it raged in epizootic form and decimated around 100 cavalry horses in 1895. Borna disease virus has recently been characterized. It is a single-stranded, enveloped, non-segmented negative RNA virus. It was classified in a new family Bornaviridae, of the order Mononegavirales. Unlike the majority of RNA viruses, the BDV genome seems to present extreme stability over time. The first isolate, strain V, dates from 1929 and is genetically close to recent isolates, from one geographical area to another, and especially from one animal species to another. This extreme stability of the virus was, however, called into question upon the discovery of a new genotype, strain No/98, isolated from an Austrian horse, outside the enzootic zone of Central Europe, which presents variability genetic by 15% with all other BMV strains. However, the amino acid sequence is conserved, compared to other BMV strains. BMV is characterized by neurotropism, non-cytolytic replication, and persistence in the central nervous system, CNS. Other sites of BMV replication have been identified, in the nervous system, peripheral and cells of the blood, thymus and bone marrow. The biology of BMV is very close to that of the rabies virus. BMV replicates in the neurons located at the site of inoculation, in the olfactory nerve or the oropharyngeal or intestinal nerve endings. It then migrates through peripheral nerves to the central nervous system, CNS, in the form of ribonuclear proteins intraaxonal and centripetally. The time it takes for the disease to appear depends on the distance between the inoculation site and the CNS. BMV replication is observed in a variety of cells: neurons, astrocytes, oligodendrocytes and ependymal cells. The BMV has a preferential tropism for the limbic system, in particular the hippocampus, then it gradually invades the entire CNS. However, the recent demonstration of viremia, most often accompanied by severe illness, calls into question, at least partially, the mode of nervous dissemination of the virus. Borna disease was initially reported in horses and sheep, but other warm-blooded animal species can also be naturally infected, such as cattle, goats, rabbits, dogs, cats, and a variety other species such as ostriches, deer, monkeys, alpacas, llamas and recently, lynxes and foxes. Experimental disease is possible in most of these species, including primates. In addition, specific BMV markers have been detected in humans over the last 10 years, particularly in psychiatric patients. Furthermore, the neurological and emotional disorders observed in humans would be highly comparable to those observed in animals infected with BMV. However, the zoonotic aspect of Borna disease is still controversial and the scientific community still remains cautious about a possible human infection and even more about the possibility of human psychiatric illness. Borna disease was observed for a long time only in Central Europe, particularly in Germany. Today, the geographical distribution of the disease is still uncertain, but infections have been described mainly in Northern Europe, the USA, Japan, Iran, and Israel. However, only a few clinical cases of Borna disease in horses and sheep have been reported outside the enzootic region of Central Europe, in particular one case in eastern Austria and 2 cases in Japan. The reason why Borna disease remains so localized despite animal exchanges remains unknown. BMV infections have recently been described for the first time in France. A first sero-epidemiological study carried out in the French equine population in 1999 made it possible to detect 14 seropositive horses out of 158, 8.9%. In addition, suspected clinical cases of Borna disease have recently been described in France. However, the incidence of Borna disease is completely unknown in the EU and France. Transmission. Knowledge is still limited about the mode of transmission. The virus is probably excreted through salivary, nasal and conjunctival secretions since BMV RNA has been detected in these secretions. Contamination occurs through olfactory means, either through direct contact with these secretions, or through contaminated food or water. The presence of BMV RNA and proteins in blood leukocytes suggests a possibility of transmission by the hematogenous route. However, direct transmission from horse to horse or sheep to sheep has never been shown. Finally, the possibility of vertical transmission of BMV remains poorly documented, even if it has been described in horses. Natural infection of horses and sheep is rare and occurs sporadic and enzootic. It has a seasonal character, its incidence increases in spring and early summer. The increased incidence of the disease during spring and summer could be linked to a more intense activity of the sport horse at this time of year or to the seasonal nature of a possible vector. In addition, the health situation of the infected livestock appears to be an important factor in the dissemination of the virus. Furthermore, the genetic homology between BMV strains isolated from animals of different species, horses, sheep, and other farm animals, suggests a common viral source. Rodents could be potential reservoirs and vectors of the virus, but their role in the epidemiology of Borna disease has not been demonstrated. The only study on the prevalence of natural infection of wild rodents did not reveal no cases of infection. Many seropositive animals, clinically healthy or with subclinical infections, may also constitute potential sources of infection for other animals and possibly humans. The infection is not systematically diagnosed, mainly because of its often asymptomatic nature. It appears that 11.5% of clinically healthy German horses have positive serology for BMV and 22.5% in enzootic regions of Germany. In stables with sick animals, the prevalence can be up to 50%. Yet the incidence of Borna disease, which seemed to be around 0.3% in 1960, in Germany, seems to be only between 0.02 and 0.04% today. The reasons for such a disparity between the very high seroprevalence and low incidence of Borna disease are still unknown. Clinical. In horses, a low proportion of infected animals shows signs. The incubation period varies, between 2 weeks and a few months. Initial phase of the disease manifests itself by nonspecific signs such as hypothermia, anorexia, colic and constipation. Acute phase, the neurological signs are varied, abnormal postures, proprioceptive deficit. Repetitive movements, teeth grinding, walking in a circle, neck stiffness, nystagmus, strabismus, meiosis associated with abnormal reactions to external stimuli such as hyperexcitability, aggressiveness, lethargy, drowsiness, stupor. Hypothermia, which can precede the appearance of the first nervous signs, is not observed in all cases since it can be brief. Final phase, paralysis may appear, followed by convulsions often associated with pushing against the wall movements, due to increased CSF pressure caused by inflammation, sometimes recumbency with pedaling and convulsions preceding death. Clinical illness lasts 1 to 3 weeks and mortality rates for sick horses reach 80 to 100%. It is now recognized that acute forms of the disease are not the most common forms. Many cases of asymptomatic infection are observed in the equine population, with occasional mild changes in behavior and/or ataxic movements, followed by recovery of the animal. For reasons that are not yet well defined today, some animals survive the acute illness and develop a chronic illness a few weeks after this phase. Recurring episodes may thus appear throughout the animal's life, due to the persistent nature of the virus, such as depression, apathy, drowsiness, fearful behavior, particularly after stress or other intercurrent pathologies. It is possible that animals infected with low amounts of BMV virus survive the acute illness and develop chronic behavioral disorders. Infectious virus can also be isolated from a horse in the chronic phase of the disease. It remains to be determined whether the evolution of the natural disease towards 3 different forms, mild behavioral disorders, severe neurological disease or asymptomatic infection, is linked to differences in viral strains, viral load or genetic resistance of the host. Borna disease can be diagnosed by serology, antigen detection, PCR or virus isolation, but no single method is sufficient to make a definitive diagnosis. Furthermore, no method is currently validated, which reflects the difficulty in establishing the diagnosis of BMV infection. Clinical diagnosis. The clinical picture of Borna disease is made up of a wide variety of clinical signs, but which are nonspecific. Serological diagnosis. It allows the detection of antibodies in the blood and/or cerebrospinal fluid, CSF, by Western blot, ELISA or indirect immunofluorescence, IFI, in living animals. However, antibody levels are most often very low. Antibodies are detectable in 100% of cases during acute illness, but they are difficult to detect in the case of subacute or chronic illness. Histopathological diagnosis. Varying degrees of encephalitis are observed. Yost-degen inclusion bodies located in the neuronal nuclei are specific to the BMV, but they are not present systematically. The sensitivity of the histological technique can be improved by immunohistochemistry, by the visualization of the two major BMV antigens using monoclonal or polyclonal antibodies. However, the distribution of infected cells in the brain is very heterogeneous. Detection of Borna cases can therefore sometimes escape detection. Virological diagnosis. Conventional methods of viral isolation from brain tissue are inconclusive due to the low number of infectious particles produced and the strong association of the virus with the plasma membrane. Nested RT-PCR. It can be applied to the brain or blood and can amplify the viral genes P24 and P40. However, this extremely sensitive technique poses laboratory contamination problems. On the other hand, viral strains presenting mutations in target genes cannot be detected by this technique. Immunohistochemistry carried out on horse brain sections, hippocampal region. A. Specific labeling of a neuron. B. Labeling of neurons and visualization of pathognomonic Yost-degen inclusion bodies, arrows. Differential diagnosis. It is important to make the differential diagnosis of Borna disease in horses with rabies, herpes virus infections, tick-borne encephalitis, botulism, bacterial meningitis, viral encephalomyelitis, West Nile fever, and parasitic. No treatment or prophylaxis is yet available. Preliminary studies for possible vaccination are underway. As with any viral infection and particularly persistent infections, prevention of infection through vaccination appears to be the preferred approach, rather than treatment after infection has become established. However, neither vaccination with inactivated virus nor passive experimental transfer of humoral immunity showed results in protection or cure of BMV infection in rats. Equine viral arteritis. Infectious and contagious disease of equines. It is a second-category health hazard. Venereal transmission and genital damage caused by this disease have significant economic consequences in breeding. Due to the potential consequences of the disease, abortions, mortality in foals, and long-term carriage of the virus in the genital tract of stallions, its economic impact can be significant for the equine industry. Equine viral arteritis is caused by an arterivirus of the Arteriviridae family. There are several strains of virus, of varying virulence, capacity to cause clinical signs in horses. The viral arteritis virus only infects equines. The disease is not transmissible to humans. The pathogen is of worldwide distribution with the exception of Japan and Iceland. Transmission is direct, following close contact by the respiratory or venereal route. Indirect contamination via contaminated equipment is described but less frequent because the virus is not very resistant in the external environment. The virus then enters phagocytic cells and reaches regional lymph nodes where it multiplies. It diffuses through the bloodstream to numerous epithelia including respiratory, vascular, uterine and seminal epithelia. Following a clinical episode in mares and geldings, the virus is eliminated and strong immunity is established. In stallions we find in 40% of cases chronic carriage and excretion of the virus in apparently healthy individuals. There are two main routes of transmission for this disease. Respiratory tract. Horses become infected by inhaling aerosols containing the virus during contact. With an equine, or its secretions, in the clinical phase of the disease, very short phase immediately following contamination, lasting 5 to 8 days. The main source of contamination is disposal. Tears, urine, semen for example, can also be sources of contamination, but much more rarely. After this clinical phase, mares and geldings completely eliminate the virus and are therefore no longer contagious 30 days after infection. Only certain intact horses can remain excretory of the virus in semen beyond 30 days. With the semen and urine of an entire excretion in the semen. With tissues or secretions from a contaminated runt, sexual way. Contamination occurs mainly from an excretory stallion, to the mares he breeds, or which are inseminated with his semen, whether fresh, refrigerated or frozen. The excretory stallions represent the reservoir of the virus. After clinical recovery, 10 to 70% of stallions remain carriers of the virus in the accessory glands of the genital tract, and excrete the virus in the semen. This excretion can last from a few weeks to several years. A healthy stallion carrying the virus, used for reproduction, can be the cause of an epidemic. In a healthy carrier stallion, mutations of the virus can appear over time, giving rise to new, more virulent viral strains. A mare mated, or inseminated, by a carrier stallion is almost systematically infected. Back on the farm, it then transmits the virus to its peers by respiratory route. This particularly poses a problem during contact with pregnant mares, possibility of abortions, or foals, cases of mortality described, other transmission routes. The virus is not very resistant in the external environment. It does not persist for more than 24 hours on an inert support, feeder, truck, clothing. Common virucidal disinfectants destroy it. Indirect contamination is however possible through equipment or people. In utero transmission, from mother to fetus, is also possible. Likewise, a donor mare, inseminated with contaminated semen, can transmit the disease to a recipient mare during embryonic transfer. The vast majority of infections are inapparent, or subclinic and go unnoticed. After an incubation period of 2 to 14 days, respiratory route, or 6 to 8 days, sexual route, equines can develop very varied and more or less marked clinical signs, particularly depending on the virulence of the strain. The clinical phase lasts 1 to 2 weeks. The clinical signs classically described can resemble a flu episode, but are most often less intense. Moderate hypothermia, T greater than 38.5 degrees Celsius, associated with general signs, fatigue, decreased appetite. Respiratory signs. Serous discharge from the nose and eyes, rarely cough, difficulty breathing. Edema of sloping areas, limbs, sheath, stomach, scrotum in the stallion, udder. Stiffness in locomotion. Urticaria. In a pregnant mare, an abortion can occur 2 to 4 weeks after respiratory contamination. Not all infected mares abort. They can abort without having presented other prior clinical signs. On the other hand, this infection has no short or long-term consequences on the mare's fertility. In the stallion, we can observe a transient SU fertility from 6 to 11 weeks, in particular due to hypothermia associated with the disease and the consequent increase in the temperature of the testicles. Stallions in which persistence of the virus is observed in the genital tract do not present symptoms, they are healthy carriers. Chronic carriage of the virus in the genital tract has no consequences on the quality of sperm. We can also observe cases of mortality in young foals, a consequence of pneumonia and enteritis, inflammation of the intestinal mucosa. Due to the potential consequences of the disease, in particular abortions, long-term carriage of the virus in the genital tract of stallions and cases of mortality in foals, its economic impact can be significant for the equine industry. After an initial contamination, horses acquire strong and long-lasting immunity. The antibodies produced by the body at the time of contamination can persist for up to 8 years in mares. However, reinfections seem possible. Histological, Vascular damages are mainly observable. This damages varies from vascular and perovascular edema to necrosis of the vascular wall with lymphocytic infiltration. Edema and hemorrhages of the intra-abdominal, intrathoracic lymph nodes, cecum and colon. Edema, hemorrhages and congestion of the subcutaneous tissue of the limbs and abdomen. Interstitial pulmonary edema or emphysema. The runt may be partially lysed or present edema itself, highlighting the virus. Virus isolation or virus genome search by gene amplification, PCR. Samples are taken from the organs of the fetus or placenta during abortion. Systematic search for a possible infectious cause during abortion is essential in order to protect the rest of the herd. When there are respiratory signs, a nasopharyngeal swab is taken. Serological testing can also be used. It consists of searching the blood for specific antibodies of the virus. The presence of these antibodies indicates that the animal has been in contact with this virus or that it has been vaccinated against the disease. The antibody level increases after contact with the virus, stagnates, then slowly decreases. It is important to compare titers obtained with previous titers to monitor the evolution of the antibody level. In the event of an increase in the level of antibodies or in the event of a positive result. Uniquely, it is necessary to do a second analysis, 14 days later, in order to know if the contamination is recent. A vaccine, Artivac, against viral arteritis is marketed in France. Vaccination is strongly recommended for all breeding stallions, particularly those most at risk. Stallions used in natural breeding, in direct contact with outside mares. Stallions used in artificial insemination but frequently traveling outside the breeding center for competition. Stallions housed in mixed structures in direct or indirect contact, personnel, equipment, with horses of lower health status. Examples: semen placement centers, breeding farms, competition/racing stables. Equine viral arteritis is a regulated disease, part of Category 2 health hazards. The samples are taken by the official veterinarian, declared by the holder, and the analyses carried out, in an analysis laboratory approved for this disease. In the event of a positive virological result, viral isolation or PCR, the result must be confirmed by the National Reference Laboratory, NRL, for this disease. A declaration must be made to the DDPP, Departmental Directorate in charge of Population Protection = Departmental Veterinary Services, by the analysis laboratory, the health veterinarian, and the keeper or owner of the equine. Its diagnosis does not lead to the application of health police measures by the state. Positive cases are managed by professionals, in conjunction with the NRL and the health veterinarian of the affected area. Intra-community seed exchanges. Screenings are mandatory for stallions whose semen is sent to the EU, with a frequency of screenings variable depending on the risk, that is to say whether or not there is exit from the collection center. Intra-community trade in live horses. AV screening is not mandatory. Public horse sales. AV tests are made compulsory for certain types of equines, by certain public sales agencies, in particular Arcana and Osiris. Export. For the export of semen, AV screening is almost systematically requested. Concerning the export of live horses, AV screening is almost systematically requested for entire horses. The disease circulates in France but most often does not cause clinical signs. Thus, a retrospective study, based on the analysis results recorded in the SIRE database as part of the control health of breeding, made it possible to estimate that 239 new cases and 177 outbreaks occurred between 2006 and 2012 in breeding mares. Likewise, each year, a few integers are confirmed to shed in their semen. In 2007, an epizootic causing clinical forms broke out in Normandy, 30 outbreaks were described and more than 200 horses were affected. 5 cases of mortality in foals less than 1 month old and 1 abortion were observed. More than 30 stallions became excretory of the virus in semen. In 2011, An outbreak was recorded in the southeast of France with a case of death in a foal. Since the end of 2018, 4 abortions due to avenue were confirmed in 4 Normandy structures. 8 animals became excretors of the virus in their semen, including 6 stallions used for breeding. Outbreaks of AV are regularly declared in different European countries each year: Germany, Italy, Spain, Poland, Slovakia, Netherlands, often associated with significant clinical signs, mainly abortions. Likewise, the search for AV in stallions used in AI at European level leads to the declaration of excretory stallions in Europe. Between 2013 and 2016, nearly 50 stallions were diagnosed as shedding the virus in their semen. This is why it is strongly recommended to request a certificate of the status of the equine with regard to the AV before purchasing a stallion in Europe.